So should I?
Cancel that.
Okay, perhaps we'll make a start. Good evening and welcome to the Association of Surgeons of Great Britain and Ireland, the Art and Science of Surgery. This was obviously originally planned for our annual meeting celebrating 100 years of the Association of Surgeons, set up originally by Lord Moynihan of Leeds. But unfortunately, because of the spot of bother that we've had with the virus, we're obviously having to take measures to present some of the papers that were meant to be presented in Glasgow at our meeting. I'd like to welcome my fellow chairman, Johnny Epstein, who's going to address some of the papers alongside myself, and I'll take liberty of starting off and kicking off with Mr. Alam's paper. These are going to be 3-minute presentations with 2 minutes of questions, so it's going to be bang, 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 and we'll get on with implementation of a surgical site infection reduction bundle to elective colorectal resections, a quality improvement project. Mr. Alam.
Good evening, everybody. As you can see from the topic itself, it was a retrospective analysis of a quality improvement project, and to look at basically whether surgical site infection reduction bundle implemented to elective colonic and rectal resections reduced the surgical site infection. The nature of the study, of course, was a retrospective analysis, and we hypothesized that this surgical site infection reduction bundle led to the reduction in the following parameters of the outcomes of the study, which were superficial surgical site infection, deep surgical site infection, and overall infection rate. So the parameters evaluated were superficial, deep surgical site infection, and overall infection rate. 4 colorectal consultants were involved in this study, and basically what we did is the study was from period 2015 to 2019, and we divided it into 2 cohort of patients. From 2015 to 2017, when the bundle was not implemented, we termed it as the historical cohort, and from 2017 Jan to 2019 Jan, we termed it as the one where the bundle was implemented as Group B. Now, the data collection was very simple. The theta system is all electronic. So we went on the theta system, and that gave us all the number of the patients we had with the patient identifiers and the labels. So we were able to get the total N number, as well as we were able to get the data from it. So once we had the theta system utilized for assessing how many numbers we had in each cohort, we went to the coding department, which codes the SSI as a complication, and they also gave us a breakdown with the patient identifiers of those 2 cohort of patients. And then we utilized the electronic patient database called Medway, which is not only prospectively maintained, but also retrospectively maintained with daily walk rounds and clinical entries. In order for the data collection to be robust, what we also did was that we utilized the patient's notes as well to ensure that the information in Medway is as accurate as that in the patient's notes. And corresponding to the patient's notes also helped us not only to keep the data robust, but also was a safety net to ensure that the data was correct. So this was basically, in summary, how we collected the data. Talking about both groups were fairly matched, in not only in terms of number, but also in age, gender, and BMI. We looked at the ASA grade from the anesthetic charts, and also we looked at whether there was no difference in terms of resections for benign reasons, benign causes, or for malignant causes. And we also looked at serum albumin levels and how many patients had laparoscopic stroke open procedure. In the current cohort, that's the one which was subjected to the bundle, the laparoscopic resections were 10% higher as compared to the historical cohort. I can't account for the reason for that, because the 4 consultants were part of the whole duration of 4 years. Now, if you look at the bundle itself, it was not very resource exhausting. It's very simple, things which we all know as clinicians and surgeons. We divided into pre, peri, and post-operative parameters. And this also led to a significant degree of education, not only for the nursing staff, whether they are pre-op assessment or at the attending desk or admitting or at the admission level, but also for the ODP, the anesthetics. So it was quite of a multidisciplinary approach to this bundle, and it led to a significant, I would say, quite a positive education for all the people involved in it. So the parameters of the bundle are right in front of you. These parameters were also not only filled by the surgeons, but also by the anesthetists, as you can see from the anesthetic components of the bundle, and by the admission nurses and so forth, as well as by the recovery staff. Now, the results were pretty, positive. As you can see from the bar charts, there was a significant reduction, not only in the superficial or the deep surgical site infections, but in overall infection rates. In the literature, the elective resection, colorectal resections have a SSI rate of about 10 to 12%, but in our institute, it was about 22%. And after the reduction bundle, we were able to elicit that it came down to about 11%. So that was the positive message out of this bundle, which we thought was very easy to implement. There are, of course, like any study, there are negatives associated with it. It was a single center study. It was a retrospective analysis. There was no randomization possible according to the nature of the study. Looking at both the groups, the only thing I would say is that we didn't look separately into the right sides or the left sides, as you know more than anybody. The left sides, then the ultra low anterior sections or low anterior sections, accounting for higher operating time, blood loss, morbidity, and subsequently translating into a higher wound infection. That's a confounding variable which we as a unit didn't look into, and perhaps it's something for the future, to reduce the heterogeneous nature of the group there. And the laparoscopic component was a bit more significant in Group E. That was the one with the bundle. So I do realize that those are the confounding variables which can be looked into, but we do think that this can also be implemented not only in elective colorectal resections, but also for emergency cases on the CPOD list. One thing that for IV prophylactic, for antibiotic prophylaxis, we use the TRUST guidelines, and the TRUST guidelines were the same for 4 years. That's coamoxiclav and metronidazole at induction. And for people who were allergic to penicillin, we used teicoplanin, metronidazole, and gentamicin. And before I conclude the talk, I was a senior registrar to 2 of these consultants, so it was easy for me to drive the study. And the other gentleman was also to the other 2 consultants. So the compliance with the bundle was about 85%. So the 15% were non-compliant, and we came to that conclusion only if the bundle checklist was not filled in, because it was part of the WHO checklist form. That made it easy for us to drive it. And second was that when there was cross cover, so if you were on call or something. So there we go. This is the summary of this surgical site infection reduction bundle.
Lovely. Thank you very much, Mr. Allen. A couple of questions. You've run over time slightly, so I'll keep this fairly short. Was it easy to get all of the surgeons on board using this bundle?
So the team involved 7 colorectal consultants. So 4 of them were very positive about it. So as I said, there were only 4 colorectal consultants involved in it. There were senior consultants. And as I said, like I was a registrar to 2, and the other colleague who's involved in it was a registrar to the other 2. So it made it easy for us to be robust with the data collection and things. So we just, the plan is, of course, that everybody should drive it, but 4 out of the 7 gives.
And I may have missed it, but who made the diagnosis of the superficial versus deep infection? Was that yourselves, or was that an independent examiner?
This was something that we brought it out before we implemented the bundle. So we did a team meeting after the M&M, and we said, listen, superficial surgical site infection is going to be just erythema and cellulitis, and deep would be something with discharge and erythema, which would require opening up of the wound. Sure.
Who made the assessment, though?
We as a team made it. So whoever was in the ward round. So that was the registrars and the consultants.
Very good. Thank you very much. I'll hand over to Johnny. For the other speakers, if you just mention next slide, please, so that Vicky can advance them. Should have mentioned that at the start. I'll hand over for Johnny for the second talk.
Thanks, Pete. So I'd like to introduce Anya Imzarovic, who's been busy because she's got this oral presentation and then a talking poster later. So thank you. You're going to present some evidence around a challenging but not always the most glamorous topic in general surgery, fistula in ano. Thank you.
Yes, indeed. Thank you very much. Together with my team at Brighton and Sussex University Hospital, we made a systematic review and meta-analysis whether or not marsupialization technique reduces the perianal fistula recurrence or not. I also put down my email on the slide, so if you do have any questions afterwards, please do not hesitate to contact me. Next slide, please. So as we all know, perianal fistula has always been reported with a high rate of recurrence, and marsupialization after either fistulectomy or fistulotomy was advocated to reduce its recurrence. And basically the objective of our study was to systematically analyze all the published randomized controlled trials out there, and whether marsupialization technique does any difference. We searched the published randomized controlled trials on available databases, and we then systematically reviewed them using the principles of meta-analysis, and our primary endpoints were recurrence, complications, surgical site infection, postoperative healing, length of stay, and any recurrence. Next slide, please. At the end, we identified a total of 4 randomized controlled trials. We can see the basically name of the trials in the forest plots. It included around 250 patients, which reported the outcomes and comparison between marsupialization and no marsupialization technique. We could see that basically there had been no heterogeneity amongst included studies, and also in the random effects model, the marsupialization itself did not reduce fistula recurrence. And also, in addition to the outcomes of morbidity, wound infection, postoperative pain, and healing, as well as length of stay, they were also statistically equivalent, so it had made no difference. Here is the forest plot of recurrence. We can see that basically the line of zero effect had been crossed, and there the trials do not favor either of method. Next slide, please. Again, similar thing, healing forest plots, again, it doesn't favor any method over another, and similar for the pain. So our conclusion is basically that marsupialization in conjunction with fistulotomy and fistulectomy fails to reduce recurrence of perianal fistula itself. Thank you.
Thanks very much. I think that's a really thorough review of the topic. I'll be honest, I feel like I've laid open a lot of fistulas. I've never marsupialized one. Yeah. I'm going to steal a line from Pete here. It's a shame he's here, because he taught me the great thing about trying a new technique for fistula surgery. You're going to get 2 papers. One to say the early results are really promising, and then a second to say, unfortunately, the late results aren't that great. And I suspect this is another technique where, unfortunately, this is a challenging problem.
Exactly.
I guess the subgroup of ones that you lay open are ones where you're optimistic anyway that things are going to go well, and actually looking at the data, I think that would support that. I just wonder if you've got any comments on that this is actually a group that do well, actually almost whatever you do.
Yeah, exactly. So laying open, but then again, multiple dressings and basically patient compliance is sometimes of an issue, but I have never seen anyone here at Brighton doing the marsupialization technique.
Yeah, but on the other hand, well done for going through it and perhaps suggesting the good news is we don't need to go and learn this technique.
Exactly. Thank you.
Thank you very much. Okay, moving on to the third paper in this session. Mr. Khan is going to address the topic of what do you do with a patient who has had previously normal investigations and now suspected to have bowel cancer? How active should you be in tackling those patients? Mr. Khan.
Good evening, everyone. My name is Mars. I'm a fourth-year medical student at the University of Liverpool. I'll be presenting with my colleague Ahmed, who will be joining me in the questions aspect of this. So today, as you said, our study looked at patients who'd been referred through the fast track process for new or persistent bowel symptoms, and in the previous 3 years they'd had normal bowel investigations, and that was what the study looked at, and the aim was to see if these patients who'd had these normal investigations in the previous 3 years, if repeating these bowel investigations led to any significant findings. Colorectal cancer primarily was what we were focusing on. Next slide, please. So, natural history of colorectal cancer and the knowledge is best depicted by the adenocarcinoma sequence, as you can see on the right. This hypothesis was used as the standard in the study, showing a colon going to a polyp to a carcinoma. And from this, we came up with the hypothesis that patients with normal bowel investigations in the previous 3 years are very unlikely to be diagnosed with the colorectal cancer within this time frame. 3 years is a bit short, given that studies have shown that it's 5 to 10 years that the average polyp may turn malignant. Next slide, please. So it was a retrospective observational cohort study taken in the Wirral Peninsula. It was taken from 2015 to 2018. The results, as you can see, the diagnostic yield of the 2-week wait pathway was 5.24%, so 426 patients were diagnosed with colorectal cancer. And what was of significance to us was the 134 patients that were referred again with either new or the same symptoms. Of those, 0 patients, no patients had a diagnosis of colorectal cancer once they'd had the repeat investigations. 8 patients did have subsequent polyps, or in one case, renal cancer and a benign adrenal adenoma. Next slide, please. So concluding, a study showed that it can be presumed safe to defer these fast track appointments and these investigations to a routine clinic in patients who have had these recent normal lower GI investigations in the previous time frame of 3 years. Potential benefits is that it's less pressure on the fast track referral clinics and the diagnostic services such as colonoscopy or OGD. And it means that patients aren't subjected to the repeat investigations, given like in elderly patients, bowel prep, going to and fro from toilet can be an issue, especially with mobility. And from an economic perspective, it saves money and resources for the local NHS trusts. Thank you.
Thank you. Very good. Good performance there for a medical student. Well done. And a very nice study too. The issue here is that we are seeing a significant number of what are called interval cancers. So you've had colonoscopy, and then within the next 3 to 4 years, a cancer is picked up. And the implication there is the cancer was missed at the first colonoscopy. It is very reassuring to see your data that there were, correct me if I'm wrong, 0 cancers picked up from those re-referrals. So that suggests you're providing a very good service in your area. But the worry we've got with patients that come back is that they have got serious pathology. So the question really is how to take these forward. Should we be reassuring all the clinicians that you don't need to be investigating? Well, that's your conclusion. Or should we be using things like the FIT test, which has since come online since you did this study or in that 3-year period, to reassure ourselves as well as your data, which I offer congratulations.
I'd like to give an opportunity to my colleague to answer that.
Thank you.
Yeah, hi. Hi, my name is Ahmed Adan. I'm also a 4th-year medical student at Liverpool. I just want to say thank you to my colleague Miles there for that wonderful presentation, and thank you to ASGBI for this great event as well. With regards to the question of what to do with those patients, I think the good idea is to refer them to the routine clinics, because when they go to the routine clinics, they are still being investigated, they are still being checked up. If anything is found, then they can be investigated further. But it's just the fact that they're referred to the fast track clinics repeatedly and subjected to the same investigations, which we think sometimes shouldn't happen, because if a patient's had a colonoscopy within the past 3 years, It didn't find anything, and they had another colonoscopy within the next 3 years again. The likelihood of there being cancer is very small. But as you mentioned, the FAST tool is a viable option, is something that we could perhaps consider as well.
So just for your information, being medical students, when this first came along as the 2-week wait, we were expecting to pick up a lot of colorectal cancers. In the first few years, around about 13%. It's fallen significantly since then, because GPs have really abused the system in the sense that have used that as a referral tool. I don't blame them, don't get me wrong. It means that the pickup rate for cancer is very low. So I think your study is very valuable. Thank you very much.
Thank you.
Well done. Well done, boys. Johnny.
Thanks, Pete. So next presentation I'm looking forward to, interest of mine. So Olukayode Oki, look forward to it.
Hello, my name is Olukayode Oki and I am a 4th year medical student at the University of Dundee. Today I will be presenting a project titled A Comparison of Surgical Resection in Inflammatory Bowel Disease in 2008 and 2018. Before I begin, I would like to thank my project partner, Nitya Anil Nair, and my supervisor, Dr. John Todd. Next slide, please. As we all know, IBD can be an incredibly debilitating and lifelong condition which doesn't have any cure, and management of it comprises of inducing remission in acute flares and then maintaining that remission. For a long time, corticosteroids have been a mainstay in management. However, they have numerous other long-term side effects. Surgery still remains a significant modality and is often viewed as the final option. The aim of the project was to compare the effects of drug class on the time to surgery and to compare how the different surgical modalities have changed. Case notes and medical records for 76 patients who had IBD resections in 2008 and 2018 were reviewed. The type of surgery, date of diagnosis, medical treatments they were on, and date of surgery were collated using Microsoft forms. Then statistical analysis was then carried out on the collated data. As you can see in figure 2, there is a significant difference in the types of surgeries conducted between both years. Between 2008 and 2018, there's been a general shift towards more laparoscopic techniques. Next slide, please. From figure 3, patients aged 40 had a shorter time to surgery, and not shown on the graph are the results of a Tukey HSD test, which shows the difference was between the over 40 and the 17 to 40 age group. There was no significant difference in the time to surgery between both years, as shown in figure 4, meaning that it remains relatively unchanged. Next. In figure 5, the use of immunosuppressants with other drug classes increased the time to surgery, and that is highlighted in the gray boxes. Surprisingly, the use of biologics reduced the patient's time to surgery, and that's in the orangey red boxes. This was unexpected, as biologics are lauded as this revolution to IBD management. We believe this is due to the increase use as first-line management in severe acute flares, which ultimately end up in surgical resection. Next slide, please. To conclude, I would like to leave you with a big question. What is the impact of using biologics as initial management of severe IBD? And are we perhaps masking their true efficacy by doing this? Should we perhaps consider using them in less severe disease and consider cycling the treatments where we give people biologics in less severe disease to achieve remission, and then restart the biologics when biomarkers suggest a flare might be imminent? Thank you very much.
Thank you. Again, congratulations. That's a very mature presentation, beautiful slides of a difficult area and a difficult topic. I think there's some challenges interpreting the data you've put up and taking the conclusions from them, but I think everything you've said is interesting and noteworthy. I think we'd all recognise increased use of laparoscopic surgery. The point you make about introducing biologics earlier is an interesting topic across IBD, whether to take a top-down approach rather than working very, very slowly and painstakingly up the way to biologics. Did you get a feel from your data set about how many of these patients were emergencies who then came to semi-emergency surgery, as opposed to how many patients had struggled along for a long time before coming to surgery?
Yes, I did. Let me just look. So in 2018, 22 out of the 22 patients were emergency, whereas 15 were elective. And in 2008, 22 were elective and 14 were emergency. So into 2018, there were more emergency cases.
Which again is interesting. And I know Pete and I would both say that there's a group of patients who we know need surgery and perhaps don't get there early enough. And that's one of the great challenges of identifying those patients. But fantastic, well done, really good work.
Thank you.
Also depends, I think, Johnny, on the MDTs in the hospital. I think it depends on the personalities to a large extent in terms of physicians versus surgeons, in terms of how the patients are handled. The benefit of having a multidisciplinary team as well as a combined colitis clinic helps the patient enormously, getting two opinions at the same time rather than bouncing between clinics and getting one opinion from a physician and a few weeks later an opinion from a surgeon. I do think the idea that surgery is a last resort needs to be got rid of. Surgery is very good to avoid the long-term effects of these drugs and avoid the complications of the conditions. There is a cost to surgery, I accept that. But let's not kid ourselves, there's no cost to the drugs either.
Yeah, definitely.
Agreed.
Yeah, okay. Very nice presentation, thank you.
Agreed.
Thank you.
I think we're now up to the posters.
I think the first one has not attended. Is it Dr. Omar or Mr. Omar not turned up? So, Johnny, do you want to introduce the second one as we had originally planned? Go with that.
Certainly, I'll just turn my page. So the next presentation is Mohammed Maturza Khan, who is here good and early, and he's going to tell us about MRI of the knee and how we're utilizing that resource.
So this is basically a retrospective audit, and what we find out in our clinical practice is like GPs are like overusing a lot of MRI. So the methodology behind this is we retrospectively evaluated all the MRI, all the referrals that have been sent to one of our knee consultants in a year's time, and we looked into it, what was the reason for an MRI, what was the outcome, and what ultimately ended up as was the guidelines followed or not. So there are very clear guidelines regarding GPs to go for an MRI scan for any patient. They are presented. They are like published by NHS Scotland, and we took it as a standard and then compared it with the MRI request by GPs. So out of the 261 referrals that we received over a year's time for one of our knee consultants, 87 had an MRI scan, and out of those 87, only 24% of these were being as per guidelines. I will briefly touch when I say guidelines, what are they? It's just like the patient has to be between 15 and 45 years of age. There should be no history of anterior knee pain, no previous diagnosis of osteoarthritis, and no previous meniscal surgery to the knee, and as well as some general contraindications to MRI. So looking into it, the compliance to it was just 24%. And to our surprise, out of all these 87 referrals, basically GP use MRI as a modality of choice to diagnose osteoarthritis in elderly patients rather than X-ray. So just 13% of these patients has had X-ray, and the rest of them all had MRI as a first choice. We moved a bit further to look what was the yield post-operatively, like post-investigation about what was the outcome of going for an MRI scan. So majority of them were managed conservatively and there was no change in outcome. It just like misuse of MRI led to false patient expectations of going for surgery that their knee will be fixed, because it usually showed a degenerative meniscal tear that as per guidelines should be treated as conservative, not as surgery. So that is all about it. And just a bit about the financial aspect. I'm sorry, my poster is not being displayed properly here. So in case of these inappropriate referrals, yearly for just single consultant referral, there was like 13,200 pounds of loss to the NHS, and this MRI didn't lead to any change in the management of patients. So that is it. The way forward from the audit or quality improvement project is I raised this issue to the CQC team in my area, and then we decided to have a chat with the GPs about how to request and when to request an MRI. And on top of it, they are also working about a musculoskeletal team system where patients with knee pain will be referred first to them. And if they think that they need MRI, they can refer it directly to our knee consultant rather than GP requesting MRI, waiting for the scan, and then finding out it's nothing serious, and then referring it to our knee surgeon.
Thanks very much. That's a really nice, clear message. And we'll...
Hello.
I think Johnny's frozen.
Yeah.
Yeah, I can't hear you, sorry.
Sorry, we lost Johnny. Okay, we'll move on.
Thank you. Yeah.
Thank you very much. Thank you for your presentation. And move on, and we'll go back to Anya Imsirovic, who's going to address another use of marsupialization to what she described earlier this evening, recurrence of pilonidal sinus.
Yes, so good evening, everyone, again. So together with, oh, sorry. So together with the team in Brighton and Western Sussex Hospital and Isle of Wight, we had a look at, again, pilonidal sinus, which has been previously reported with higher rate of recurrence, and sometimes marsupialization after excisional surgery was considered to reduce its recurrence. And the objective of the study was to compare the outcomes, whether the marsupialization had made any difference. We had searched the electronic databases on this topic, and the articles were systematically reviewed using the principles of meta-analysis, and our study endpoint, which you can see were recurrence, surgical site infection, post-operative pain, length of stay and return to work, alongside healing time, everything what you can measure. In the results, a total of 5 randomized controlled trials, which are again listed here, had been identified on 340 patients, comparing the outcomes between marsupialization and non-marsupialization group. And again, there was significant heterogeneity among studies, meaning that in the random effects model, the marsupialization did not reduce any pilonidal sinus recurrence. And again, outcomes of the wound infection, post-operative pain, healing time, return to work were statistically equivalent. However, we found out that the length of stay was shorter in non-marsupialization group, which makes sense. And therefore, we concluded that marsupialization in conjunction with pilonidal sinus excisional surgery failed to reduce its recurrence. Thank you.
Thank you. Nice presentation. And again, marsupialization seems to fail. I'm not quite sure how that's going to work. Presumably, you're excising and then marsupializing, so you're not closing the wound.
Yeah.
By definition, you have to do that to marsupialize. The one thing patients don't like about pilonidal sinus surgery is the need to pack the wound, which can take, well, literally years. I've seen some patients take 2 to 3 years for these things to heal.
Yeah.
Would marsupialization therefore be something that patients would not want on the basis that it's going to be a slow healing process, accepting that primary excision and primary closure often leads to a breakdown, therefore packing? How keen would patients be to have marsupialization?
Well, I think it depends from the patient to patient, and you have to counsel everyone separately and basically decide and give it a go. Some patients are very keen and are very compliant with treatment, some of them are not, but I think it's important to identify if it's an elective procedure, if it's not done as an emergency, as a simple incision and drainage and then packing.
Great, thank you.
Within your reading, will you pick on the value of shaving or depilatory creams, etc., for patients who have marsupialization? Did that make any difference? And would you recommend that for pilonidal sinus surgery in general?
Sorry, could you repeat that? I didn't hear the first part.
Shaving, depilatory creams, laser treatment, eradication of hairs. Do you think that makes any difference? Patients always ask.
Yeah, I know. In my opinion, it doesn't, but there's always the recommendation of good hygiene, sort of shaving of the area recommended, but I hadn't seen, I hadn't done much clinics, but I hadn't seen much of a difference so far. I'm only a clinical fellow as an or any equivalent.
I agree with the comment about good hygiene. Females do much better than males, and males with poor hygiene seem to do worst of all, but perhaps you'd expect that.
Yeah.
Okay, thank you very much. Very enjoyable. Johnny, oh, Johnny's back. Good.
Sorry, I had a brief moment there. Thank you. I'd like to introduce Umesh Jayaraja, who's joining us from Colombo in Sri Lanka, I think. So thank you, and interested in your poster.
Thank you very much. I hope you can hear me well. I'm Umesh, I'm from Sri Lanka, and this study is titled Surgical Outcome of Feminizing Genitoplasty in Children with Disorders of Sex Development, that is DSD. This study was conducted at the Faculty of Medicine, University of Colombo. Feminized genitoplasty is a complex operation which has attracted some controversy in the recent years and decades, and it's performed in girls with realization with the aim of achieving anatomy in line with the sex appearing to facilitate normal psychosexual development, cosmetic, sexual and reproductive function. Although there are studies, many studies in the Western countries, there is lack of consensus related to the surgical management of DSD, and the data available in the developing countries, including Sri Lanka, is very limited. Therefore, we aim to assess the surgical outcome of feminizing genitoplasty and its associated factors among Sri Lankan children with 46XX DSD. So this is the descriptive study that was conducted among 24 children between 2008 and 2016. And the surgical outcomes were assessed by the surgeon in terms of the anatomy, the cosmetics, and the complications of surgery. So we had 24 children altogether, and the mean age at review was 10 years. And the mean age of surgery was 3.5 years, which is compared to the Western, which is quite early. And the duration of the surgery is around 15 months, that is from 1 year to about 10 years, the range. And we had various types of surgeries performed in these patients. So the type of surgery includes a combination of clitoroplasty, vaginoplasty, and labioplasty. And 23 out of 24 children underwent all three. And one child underwent clitoroplasty only. So of those, so the tables, they summarize the type of surgeries that were performed. And the majority underwent single-stage surgery, that is 20 out of 24. And the multi-stage surgeries were performed in 4. And overall, the outcome was good in 65% and satisfactory in 30% and poor in 4.3%. So we assess the outcome in terms of the each anatomical perspective, in terms of the clitoris, the vagina, and so on. And the good means if all the components are satisfactory, we term those good. And if it is, if one component is not satisfactory, we call that satisfactory, and more than one component were unsatisfactory, we call that poor. And regarding complications, so the summary is provided in the table that is given here. And important complications were urinary incontinence, which was seen when there was post-urogenital sinus mobilization. So 3 children had urinary incontinence, and all 3 of them underwent total urinary sinus mobilization. And vestibular scarring was not an important complication. Again, it was seen in complicated surgeries, such as in vagina substitution, total urinary sinus mobilization, and in patients who underwent multiple surgeries. So all in all, the surgical outcome was satisfactory in the majority of patients, and the complications were associated with complex surgeries. And taking this into account, we suggest that the technique involving total urinary sinus mobilization for girls with high confluence of urethral tightening is to be reviewed. And further studies need to be conducted in the nations to see the importance of early surgery versus late surgery. Thank you very much.
Thank you. I had trouble with the sound towards the end there, so I'm sorry about that. I don't know if other people did as well. Thank you. I mean, this is a really challenging area and not one I'm going to pretend to be expert on. I know, because I spoke to a colleague, that you've got a unit here where you bring together endocrinologists and paediatric surgeons. You've got something really interesting. I note the outcomes you've looked at were all from the surgeon's perspective, which clearly is valuable. But I wonder if you've got any plans here moving forward to follow these patients long term and get some patient-related outcomes here, because I think that would be really interesting and useful as well. I just wondered if you ever had any thoughts about that.
Sorry, because of the connection problem. Could you please repeat the question? Hello.
I do apologise. I'm struggling. I'm personally struggling to hear you. I don't know if other people are. It looks like other people are as well. So can I just thank you? It's really really pleased that you've submitted your work to ASGBI. I think it's a really important, interesting topic as well. So thank you, and just encourage you and your colleagues to submit your work. I'm very grateful.
Thank you very much.
Okay. So thanks. So back over to you, Pete.
Thanks, Johnny. Okay, the penultimate paper will be from Ruth Miller from Renfrewshire, talking about the perioperative pathway and the value of prehabilitation, which we've certainly been interested in Leeds. So hand over to Ruth, we're very interested in her presentation.
Thanks, Pete. So yes, I'm responsible for working with the health professionals in Renfrewshire to integrate physical activity into the patient pathway. So right from prehab onto the community referral after their care. So the aim of prehab, for those that don't know, is to improve patients' health prior to their surgery. Quite a simple concept. There's been RCTs that show in high-risk patients we can have up to 51% reduction in surgical outcomes for those who go through prehab. So the evidence was evolving, which is great, but we wanted to look at how we could implement this into practice. We already had a rehab pathway in place which seemed to work, but we felt like we were missing a trick, maybe a bit too late and missing that teachable moment. So we reviewed the pathway in the RH where I integrate physical activity. It's normal for a community referral at discharge. It's normal for your enhanced recovery nurse to drag you out of bed pretty quick after surgery. So we wanted to try and create the same picture with prehab. Can it just be seen as the norm, part of their treatment? And everyone that they were coming into contact with, every healthcare professional had the same message of the importance of improving health prior to their surgery. So what we did is we started a outpatient specific prehab clinic, which sat between 2 surgical clinics. Patients were screened, given a personalized prehab program. This was mainly physical activity, but touched on smoking, alcohol, psychological well-being. We took some baseline measurements and we supported the patient right up until their surgery, inpatient and then into the community afterwards. Patients were sent resources, DVDs, pedometers, and also a patient app for a bit of accountability, and we were able to track as well. So for the first 6 months, we had 49 patients that underwent prehab. The majority opted for hospital-based activity, and the average supervised session was 6 attendances prior to their surgery. We saw improvements in moderate to vigorous physical activity, weight loss, grip strength, and sit to stand. with all patients actually improving their weekly moderate to vigorous physical activity. And great feedback on the physical, psychological, and social health benefits too. And so from that, we took that prehabilitation can be integrated safely with positive outcomes into the perioperative pathway. It's important that it's individualized, and we consider the hospital-based aspects of assessment and delivery to optimize patient engagement. Kind of given the idea that it's part of their treatment, it's part of their care plan. And just to end, note, thinking of this and the after effects of COVID-19 in functional capacity, I think it's now more important than ever that we optimize patients prior to their surgical intervention. Thank you for listening.
Thank you, Ruth. That's great. I do find it very interesting that a relatively short period of time can bring such a big improvement with loss of weight, improved strength, and so on. I don't think you mentioned it in your talk, how long you spent with them. If you got bowel cancer, you'd like to think you're operating within, well, 31 days or so. Why do you think it is that such a short period of time can have such a big effect on patients? Is it because the baseline is so low, or is it because you guys are so enthusiastic, you drive your patients to do plenty of exercise in that short period of time?
Oh, it's definitely the latter.
Susan was telling me to exercise, I'd get out my bike and start
cycling.
Definitely
the latter.
Terrified
I
of
think
that.
it's a bit of both. Yeah, it's a mixture. As you probably know, the west of Scotland, we aren't the most fit population, so we do have quite high-risk patients that we can work with quite intensely. It would just depend on the individual to how intense that would look. It would be a mixture of obviously hospital attendances and home stuff that they can supplement that with. So, yeah.
It is encouraging though, isn't it? A relatively small amount of change to your life could have such a dramatic change. I know there are data that support improved outcomes because of that. So this should absolutely be encouraged.
Yes, it's trying to jump on that teachable moment as much as we can, which seems to be prehab's that ideal time.
Good for you. Keep up the good work.
Thanks, Pete.
Thank you. Johnny.
Thanks, Pete. So now Anya Imzirovic has got another presentation. So thank you. I'm glad you made it this evening. And you're going to tell us now about intraperitoneal local anesthesia.
Exactly. So hello again from my side, alongside with colleagues from Brighton. We again had a look at preemptive intraperitoneal anesthesia, whether it's effective as an immediate post-operative pain management in lap appendix. As we all know, lap appendix is most often a day case procedure, but sometimes the post-operative pain management is one of the key factors that's basically either preventing or enabling patients to be discharged safely. The objective of this study was to systematically analyze the published randomized controlled trials out there. And again, we searched the electronic databases available and reviewed the articles using the principles of meta-analysis. We identified 4 randomized controlled trials on roughly 420 patients, which were undergoing lap appendix and were either given intraperitoneal local anesthetic or standard postoperative oral analgesia. And in the random effects model, we could see that 3 to 4 hour pain score and 12-hour postoperative pain score were significantly lower in the intraperitoneal local anesthetic group with P around 0.4. However, the postoperative nausea and vomiting, as well as shoulder tip pain, length of stay, and other parameters were statistically similar in both groups. Therefore, we concluded that the intraperitoneal local anesthetic infiltration is an effective method to reduce postoperative pain score in patients undergoing lap appendix. Thank you.
Thanks very much. You present your data very nicely, so thank you again. What I wanted to ask you about this is, and I think you've answered the question, but I just wanted to ask again, really. The comparison is between intraperitoneal local anaesthetic and you said standard oral.
Yeah.
And I guess for me, we have an amount of local anaesthetic we can give, and to me the bigger question is where we're going to give it. And there's been a number of papers this evening, not all of them made it to the final presentation, looking at intraperitoneal anaesthesia, and I didn't see any of them where they compared intraperitoneal versus local installation directly into the wound. I wondered if you have a thought about that, if you came across any studies, because I wonder if that's the more interesting study.
I think this would be, but I hadn't had a chance to get across of that study. I think it makes a difference even in, for example, I have gallbladder. When you do install in the gallbladder wound afterwards, it makes a difference and reduces the pain afterwards. So patients that do get then discharged home with oral analgesia tend to take less. So it would be an interesting finding to see how it all works up in appendixes.
Excellent. Well, thanks very much.
Thank you.
Okay, that wraps up the talking posters and wraps up the evening. I'd like to thank all of the speakers today for some very good and very stimulating presentations, and thank my fellow chairman and old friend Johnny Epstein for his excellent work. And thanks for coming back, Johnny. I haven't lost you for a short period of time. On Thursday, we've got a further webinar with Neil Welsh and Gillian Teeny and a few others presenting pre-pyloric problems. And this time next week, we've got a further set of abstracts being presented. So thanks again to all the speakers today. It's been an excellent session. Have a good evening and good night.
Night.
Thank you.